Oh,
see some of the other states that I've been
I
to.
think California in particular, yeah, for sure.
We,
Yeah,
we, we still sort of do it.
yeah.
And then she'll pass it to you to give them.
Okay.
Okay, got it.
Are we good to go ahead and get started? Looks like yes. All right. Thank you, everyone, for joining us here today. My name is Colleen Chavla. I'm the director of the Alameda County Healthcare Services Agency, and I'm going to be your moderator for today. Before we get started with our roundtable discussion, I want to start with a land acknowledgement led by Satanzi Montez, please.
Good morning, everybody. I'm Satanzi Montez of the Navajo, Apache, Cherokee, and Second Nations. Currently, I'm a student at San Francisco State University, double majoring in American Indian Studies and pre-nursing, and I'm a student intern at the neighboring health center. And I would like to share a land acknowledgement with you today. Today, we are gathered on the original ancestral homelands of the Chochenyo-speaking Ohlone tribes of the East Bay. We honor the Ohlone people who have cared for this land. Who have cared for this land through the generations with respect and reverence, and we are thankful for their past, present, and future contributions. I would like to call on all those that are living, working, and playing in Ohlone territory to learn the true history of this land, to engage in meaningful relationships with the tribe, and to move beyond land acknowledgement. And I would like to honor activist Karina Gould of the Confederated Villages of the Luzon Nation, who works to return Indigenous land to Indigenous people. And I would like to thank Dr. Stephen Chen for inviting me to this important discussion on bridging food as medicine and making space for this land acknowledgement. Thank you.
Thank you.
Thank you. Thank you very much, Satanzi. At this point, I'd like to turn it over to our esteemed federal and local leaders for some opening remarks. I'll start with Congresswoman Lee.
Thank you very much, and thank you so much for reminding us. We always have to be reminded of whose land this is. Thank you very much. Good to see everyone. And Colleen, thank you so much for doing the heavy lift, being our moderator this morning. And I am so pleased to host today our roundtable at the Wilma Chan Highland Hospital campus to welcome back our secretary, who knew Supervisor Chan very well, Secretary Javier Becerra. And just a couple of things about Wilma. I knew Wilma for many, many years. I mean, since the 80s. We started out together on a lot of campaigns, many efforts for justice. And I miss her tremendously. And it's so appropriate that we begin and continue this initiative in her name and in this hospital, because she never gave up, and she was a visionary. And it was at our first roundtable with Secretary Becerra that Wilma talked about food as medicine and why we needed to look at this holistically and develop a federal strategy around this, which we finally did. And so I want to thank you to our CEO, James Jackson of the Alameda Healthcare System, for providing this space and for your leadership to deliver healthcare to our communities. And I'm always reminded of his dad, and I just have to mention Dr. James Jackson, who many of us knew in this community as a great physician, but a person who loved the community and loved people, regardless of who they were. And Lena Tam, where's Lena? Lena, thank you very much for your leadership and for being here also. And I know Wilma is proud of you too.
Thank you.
Our discussion today hopefully will uplift Supervisor Chan's legacy. Alameda County's Food as Medicine program is called Recipe for Health. So Dr. Chen, thank you very much. Where are you, in Washington? Feels like Washington here. Because your efforts, you've been such a critical strategist in our efforts here in Alameda County in terms of Alameda's comprehensive food as medicine nationally. And I would like to welcome and acknowledge that you have had an incredible group of roundtable participants on several of these roundtables, but also here today, who significantly contribute to addressing overall health disparities in our community. So thank you so much for being here. So once again, Secretary Becerra, thank you very much. You know, many of you saw what took place as a result of the COVID response as it relates to our communities of color, which were disproportionately impacted by the COVID pandemic. Well, our secretary worked with myself to make sure that the funding and the resources were available to our community clinics and to our communities based on impacted communities and where the need was the greatest, where people were getting sick and dying the most. And of course, that was a heavy lift, but we did it. So thank you, Javier, very much. And then finally, following up from our last roundtable, finally got the Appropriations Committee to put in, and I'll just briefly read just a portion of that, $2 million to begin a national food as medicine program. And this never would have happened had it not been for Supervisor Chan and all of you who were at that first meeting. And so just basically what I wrote in and we'll be able to negotiate was in the appropriations bill, America's access to food as medicine and healthy, nutritious, organic, and affordable foods are extremely important, especially in at-risk communities. The agreement includes $2 million in the Office of the Secretary to establish a food as medicine pilot program, an integrated model for healthcare that addresses food insecurity, social isolation, and chronic disease to advance health and racial equity. And so, Mr. Secretary, you know, so much of what I do comes from my district. This came from right here, this $2 million, but we've got to get it to $50 million and more, okay? But this is a starter. So thank you very much, Mr. Secretary, for your help, and welcome again to Alameda County and to Oakland.
Yeah. Congresswoman, first, thank you very much for having us, and I would love to see you get it to 50 million. We will make sure we deploy it. I want to make sure I thank you for the work that you've really undertaken with the teams that you have here, but with some of your colleagues as well who understood the value of this. I'm going around the country these days, and I'm trying to highlight the fact that we spend so much money needlessly because we're not so much a healthcare system, we're an illness care system, right? We wait till people get ill before we actually offer them care and treatment. And rather than be a wellness care system, we wait till it's kind of late for too many, especially those who don't have easy access to care. And so if there is an effort to move towards a wellness care system, food has to be treated as medicine. Because so much of what impacts your health will be what you eat, where you live, if you have a place to live, and what kind of access you have to the kind of assets that a community can offer, those social determinants of health. And so we are all in. Oregon has taken us up on the challenge, and they are now moving forward with a program that allows them to treat food as medicine. Massachusetts has taken us up on that challenge. California has an innovative waiver where they're going to try to use their Medicaid dollars in that way as well. We're ready. We just want to see the proof, because we know we have to go back to Congresswoman Lee and her colleagues and show that this works, so we can expand it and go beyond just $2 million and get it so that all communities have this. I would love nothing more than to see a pediatrician tell a parent, so your child's pretty good, a little deficient in this vitamin and needs a little bit more exercise. I'm giving you a prescription, need some more berries, got to eat a little bit more asparagus, don't worry about the broccoli. And then you have the grocers who will take that prescription and say, aha, I see you've got a prescription, you get a 20% discount on those medicines that you're about to buy from us. Then we will become a wellness care system and not just an illness care system. We're ready. We want you to push us and challenge us. And so to Supervisor Tam for the work that the county will do working with your health department, Colleen, to you and all your colleagues that are doing some of this work already, to Dr. Jackson and his teams here on the ground, we say, push us. You had us at hello. And so just make us work, because this will finally take us to where, well, as I'd like to mention, where Frederick Douglass, about 160, 170 years ago, said, it's easier to raise strong children than to repair broken men. My mom had a way of saying that was even more concise. Mejor prevenir que remediar. Better to prevent than to remediate. In healthcare, this is what it's about. Let's prevent rather than just remediate. We're on board. Thank you for having me.
Thank you so much. Supervisor Tam?
Good morning. I have very big shoes to fill as the new supervisor for District 3, succeeding the late Supervisor Wilma Chan. And it's truly an honor to be able to welcome all of you, especially Congresswoman Barbara Lee and our federal partner, Secretary Javier Becerra, for convening this Food as Medicine Roundtable. And this is something that Supervisor Chan was envisioning when we were celebrating the 50th anniversary of the war on poverty that President Johnson had initiated. And she started this in Alameda County because it was her vision to eradicate poverty in Alameda County. So what happens when you bring some key ingredients like healthcare, food, agriculture, and public policy to address food insecurity? You get the birth of the recipe for health. This is what we're talking about today. So as a result of all of your collaboration, the innovation and the partnerships, Recipe for Health has become a reality. So I wanted to take this opportunity to congratulate all of you for making Recipe for Health possible and for being recognized nationally with the National Association of Counties for the healthcare achievement. So I look forward to the outcomes of today's roundtable, and I want to thank all of you again for coming together and helping us deepen and strengthen the Recipe for Health program.
Good morning, everyone. My name is James Jackson, and I'm the CEO of the Alameda Health System. I want to start by just, again, saying thank you for the land acknowledgement. That is extraordinarily powerful and important that we continue to remember whose land we are on. I'm a son of Oakland. I was raised here, and I feel very fortunate to have the opportunity to serve this community, which is the community that I love. It's a great honor to host you, Secretary Becerra, and Congresswoman Lee. I can't say enough how much it means to me that you have those fond recollections of my father, and I'm grateful for that, and all the work that you do for this community in the past and in the future. Absolutely. And of course, Supervisor Tam, I am looking forward to the partnership between your office and the Alameda Health System. I know that we're going to do great things together. And I want to thank all the rest of the folks here who are gathered. I see many faces, and I've met many of you individually, and I really think the synergy of what we can create together is just so exciting. And so my gratitude to our electeds for coming here and helping create this forum so that we could talk. And I'm going to talk about Dr. Chin in just a moment. I want to start off by just talking about this community a bit. Oakland's renowned for creativity as well as the innovation of our citizens. Mark Hamill, who many of you know as Luke Skywalker from Star Wars fame, came from Oakland. You have the NFL icon, Marshawn Lynch, musician Sheila E. They all hail from Oakland. Of course, our vice president, Kamala Harris, is from Berkeley, and she went to school here in Oakland. And if I'm not mistaken, our congresswoman spent her formative years here at Mills College. Yeah, so a lot of great creativity as well as innovation stems.
I think Ron Dellums was born at Highland.
Well, you learn something new every day.
It's Black History Month.
Thank you for that. That's going in my notes. Thank you. So a lot of creativity and innovation stems from this community, and I believe that's driven by the fact that we have an extraordinarily diverse community here in the Bay Area. Alameda Health System is the safety net that serves the most marginalized among us. Our mission of caring, healing, teaching, and serving all means that we not only treat disease and injury, but we also address the health inequities that lead to illness. I believe that it's fitting that we hold this conversation here at the Wilma Chan Highland Hospital campus, where our staff treat the disease and poverty and racism every day. Healthcare workers who treat communities like ours know that inequity is a health crisis. that's as real as COVID-19. We can measure it in rates of diabetes, hypertension, asthma, and infant mortality, and ultimately life expectancy. I believe this raises a question, and that is, how should we treat health inequity? One of the most fundamental and impactful things that we can do is make sure that our patients have nutritious food to eat. And on behalf of the Alameda Health System, I want to thank you all for allowing us to host this discussion to improve the health of our communities. Oakland is a beacon of innovation. I'm proud that we're here today to introduce the Food as Medicine model, led by my friend and colleague, Dr. Stephen Chen. And I see him with a little smile there. But Dr. Chen and I started working at AHS right at the same time. We were in orientation together. And I remember listening to him talk and saying, boy, I want to work with that guy. And I ended up being the administrator for the Hayward Wellness Center, which is where Dr. Chen really brought this idea to fruition, and it's grown from there. And so I lovingly call him my brother, and I'm just so grateful and proud of you, Stephen, and I'm just looking forward to the great things that you're going to do. I'll end by saying I hope this is one of many conversations across the country illustrating what we can accomplish when we work together across disciplines at the local, state, and national levels. Thank you.
Thank you so much, James, and thank you to all of our leaders here at the federal and local level. We are so appreciative of all the work that you do, not just on this issue, but on the many issues that so many people in this room care about. So thank you very much. And at this point, I'd like to turn it over to Dr. Chen. Of course, we're all here because of the innovative work that Dr. Chen has spearheaded, not just here in Alameda County, but across the nation. So Dr. Chen, please walk us through some of the context and background before our roundtable begins.
Thank you so much, Director Chawla. My name is Stephen Chen, and I'm a family medicine physician and the Chief Medical Officer for Alameda County's Recipe for Health. I so appreciate having this opportunity to see Congresswoman Lee and Secretary Becerra again since our last roundtable about a year and a half ago, called by the late Supervisor Wilma Chan. I'm going to tackle the following two questions. So we're going to go quick because I know we got a lot of folks here that you're going to hear from. The first question is, where does the food in Food as Medicine come from? Where does the food in Food as Medicine come from? And why bridge Food as Medicine, sourcing the food organically and regeneratively, and equity? So let's begin. Every day in any community health center in America, low-income patients who are predominantly BIPOC are suffering disproportionately from chronic conditions like diabetes, hypertension, depression. You know this, you live this, you understand this. Yet, and as the Secretary said, an often overlooked key driver for these conditions is a poor quality diet. What we eat directly contributes to our health or lack of health. And the lack of access to high quality, nutritious food in our communities only exacerbate these chronic conditions. Alameda County's Food as Medicine program, called Recipe for Health, solves this problem with 3 ingredients. That first ingredient is a food pharmacy, which is similar to a typical pharmaceutical pharmacy, except that instead of supplying pharmaceutical meds, the food pharmacy supplies a variety of food-based interventions in healthcare. In our food pharmacy, patients receive organic and regeneratively grown produce weekly for 3 months, prescribed by their health providers to treat their health condition. In other food pharmacies, it may look differently. It may be a food-based intervention that's like a medically tailored meal or something else. The second ingredient is our behavioral pharmacy. And this is where patients get access to group and individual health coaching to support long-term behavior and life habit changes. That extends the power of that 3-month prescription to amplify and sustain the effect of the food. Finally, the third ingredient is the Food as Medicine training, which provides a patient, a healthcare team trained on how to use food as medicine to treat, prevent, and reverse chronic conditions. The training is critical to implementation. To top it off, here in Alameda County, these services are now covered free for the patients by Medicaid as part of California's 1115 Medicaid waiver. The great news is this. Thank you again to Congresswoman Lee and Secretary Becerra for your federal leadership, because you have aligned the stars to scale this model and this work to work nationally. Congresswoman, your National Food as Medicine pilot, Secretary Becerra's CMS and the CMS team's 1115 waivers in 9 states now that have approved or are awaiting approval. The president's call to expand Medicare and Medicaid beneficiaries access to food as medicine, naming the VA and Indian Health Services, the stars are aligned. The challenge we face, the challenge you face as you scale this food as medicine is the real possibility of a race to the bottom when it comes to the quality of food. Without asking the question, where does the food in food as medicine come from? The cheapest food will win. And we know where that leads to. That ultimately contributes to worse outcomes for our patients. Other questions that arise: how will you build enough agricultural supply for this type of organic and regeneratively grown food to keep up with the demand from healthcare for food as medicine? Another question: how will equity guardrails be set up to ensure local, regional, and BIPOC communities are not left behind? The good news is this: when we built this model in Alameda County, we anticipated these friction points and implemented our program accordingly to address these challenges. We intentionally designed our 3-ingredient model to be a template that's adaptable to regional, geographic, and cultural variations across our country. So when we think about scaling across the nation and building this North Star of organic and regenerative sourcing, we recognize very clearly that this is not an overnight change. There will have to be a transition pathway for conventional farming to convert over time to organic and regenerative. And by intentionally connecting the demand side of healthcare, we in healthcare, to the supply side of our organic and regenerative farms, we create force multipliers in health at an individual level, an economic system level, and an environmental level. At an individual level, when you as a patient eat that organic and regeneratively grown food, that higher nutrient dense food enters your gut, nurtures your microbiome and your gut health, lowers your cholesterol, lowers your sugar spikes. You avoid the pesticides that wreak havoc on your gut and have been associated with higher rates of cancer. When you, as the farmer, grow this food this way, you, as a farmer, have less pesticide exposure and all of its negative consequences. You are now part of a local, regional economic system that is creating jobs and paying you a living wage, creating jobs for processors, distributors, and transporters, other members of your community. This economic benefit becomes a force multiplier for health as the resources are invested locally to help reduce poverty and increase jobs towards a health-producing economy. And finally, this force multiplier for health comes in improving soil health, if you believe that. Improved soil health means decreased greenhouse gases through increased carbon sequestration in the land, improved water usage, and resilience to flooding and drought. These climate benefits become a force multiplier for community health as we build more resilient supply chains in the face of more and more climate catastrophes. When you do all of the above with equity guardrails in place that ensure BIPOC supply chains of farmers, processors, and distributors, you are building wealth locally and in particular for communities of color. These are force multipliers for health. This is what we've done in Alameda County at a high level, ready to share this. I want to thank you for your time and attention. You're about to hear from other members of the team based on the questions that Director Chawla will be asking. Thank you so much.
Thank you so much, Dr. Chen. As the head of the county agency that's rooted in addressing the social determinants of health and providing holistic safety net services, I am proud that our Recipe for Health program is housed in the Healthcare Services Agency and that we're supporting our local community-based organizations with Medi-Cal claiming and reimbursement. And of course, we are not in this work alone, as Dr. Chen just said, and there are many partners here around the table who have important perspectives to share with our leaders today. So we'll focus the first part of our discussion on the opportunities available through Medi-Cal, California's Medicaid program, and the second part on the circular food economy and the importance of high-quality regenerative food. So I'm going to go clockwise around the table and ask every one of our speakers to introduce themselves and their organization, and then maybe respond to the question that I posed to each of you. And I know we are on a tight time frame, so if we can be brief but thorough in our response, that would be fantastic. So Scott, I will start with you. Can you share why the Medi-Cal plan that you run uses the CalAIM Medi-Cal 1115 waivers to expand access to high-quality food through Recipe for Health.
Good morning, I'm Scott Coffin, CEO for Alameda Alliance for Health. Over the last several years, we have expanded supports and services beyond hospitals and healthcare settings by reaching directly into California communities. The medically supportive foods are requested by our members in Alameda County, and people are asking for medically supportive foods across the state. And we know that Recipe for Health provides this food-based support and engages our members in using food as medicine to improve chronic conditions. In addition, this program creates partnerships between health centers and community-based organizations like Dig Deep Farms and Open Source Wellness to provide an integrated experience for our members. As the primary Medicaid health plan serving over 350,000 adults and children in Alameda County, our decision is and has been to pay for higher quality food that is pesticide-free and to make this food accessible to eligible members. And it's the right thing to do. In the long run, we anticipate that the health outcomes will improve and that the utilization and costs incurred by the health system are going to reduce. And something Dr. Chen said that really jumped out to me is that the cheapest food wins. And I believe we can overcome that through this program. Thank you.
Thank you, Scott. Hillary, could you please share a little bit more about the benefits of using 1115 Medi-Cal funding to pay for organic and regenerative food?
Hi, I'm Hillary Bass. I work for the Alameda County Sheriff's Office, and Dr. Chen stole a lot of my thunder of the things I was going to say, but that's okay, because we go back to the beginning of this model when he was at Hayward Wellness Center. And my boss and I, Captain Nidifer, we started Dig Deep Farms back in 2010 in Ashland, unincorporated Alameda County, because we wanted to create jobs for people primarily coming out of periods of incarceration as a way to interrupt cycles of recidivism and crime. So really we came at this from an economic development lens. And we had learned that, from Van Jones reading his book, that there's an opportunity to create economic development opportunities in a green sector. And we wanted to do that. What we learned relatively quickly was that in order to pay people living wages, the traditional business model in America of buying produce doesn't work. So we needed to find another strategy to actually create funding revenue for the food that will pay living wages for the farmers. That was when we were able to initially pilot food as medicine back in actually 2015 or 2016, but it wasn't until meeting Dr. Chen at Hayward Wellness Center and ultimately meeting Scott that we were able to move toward where we are today, where Medi-Cal can in fact reimburse at a viable rate for this food that supports the producers. All of the farmers at Dig Deep Farms are BIPOC, many women that are farmers, and we're working to develop a Black Farmer Collective in Alameda County to support more Black farmers coming in. But the only way that works is because of this model where the reimbursement is sufficient to pay the producer so that they too can become homeowners one day and be really successful in producing this, because it's producing medicine, not just sort of traditional agriculture. So thank you for making this happen, and thank you for your advocacy this whole time.
Thank you, Hillary. As we know, it's so important to pair food with support. Elizabeth, could you please share how we amplify and sustain the food prescription through behavioral and nutrition support?
Sure, thank you. I'm Dr. Elizabeth Markle. I'm a professor of community mental health and executive director of Open Source Wellness. Open Source Wellness is an Oakland-based nonprofit with a mission of delivering what we call community as medicine. And as part of Recipe for Health, we provide group health coaching with a culturally relevant whole person focus. And we really uplift 4 pillars: physical activity, healthy food, stress reduction, and social connection. And I want to answer your question in 2 ways. First, no matter how good the produce that we provide our patients is, for most of those patients, at some point, the prescription comes to an end. And when that happens, if we want our patients to be successful in sustaining the gains that they made over time, they're going to need a few things in place. They're going to need new skills to choose, prepare, and actually enjoy healthy food. They're going to need new habits in place to do so. They're going to need the self-confidence and the self-efficacy to continue doing so over time. And they need a community to support them in this new trajectory of health and well-being. And open source wellness, as part of Recipe for Health, serves as a delivery system for those things. Secondly, and I hope everybody in the room can relate to this, when we're eating poorly, or let's say when we're eating in a way that's not necessarily aligned with our values, it's not always about lack of information, right? There are moments when we're about to dig into that pint of ice cream at 10 p.m. and we are perfectly aware that it's maybe not the healthiest choice available to us, but we do it anyway. So why do we do it? We do it because we're managing another aspect of our experience. We're managing our stress, our anxiety, our loneliness, our grief, our trauma, maybe just our exhaustion. And our patients are exactly the same. They're managing stressors related to COVID and financial insecurity and intergenerational trauma and racial inequity, and the list goes on. So if we want to be effective in creating health transformation, in addition to tending the external ecosystem of agriculture and equity, which our team is doing such an incredible job of, we also need to be tending to the internal ecosystem, helping our patients build their own internal strengths and resources, and to build interpersonal resources or collective resilience so that they can maintain the gains and opportunities afforded to them by food as medicine. So right alongside food as medicine, we say and we deliver community as medicine. Thank you so much.
Thank you so much, Dr. Markle. Dr. Jenkins, are there special considerations like training that are needed to successfully implement Recipe for Health in a federally qualified health center such as Native American?
Yes. Hi, thank you for having me. I'm Dr. Gerard Jenkins, Chief Medical Officer at Native American Health Center. When I think about that question, I really think about what most of the providers and doctors have kind of been through in terms of their education and training. One of the things I'll say is that I had maybe, and Stephen knows this, Dr. Chin knows this, is like maybe 30 minutes, if not an hour, of training on nutrition in medical school. That's it. And it came at like the end of the year, like at the end of the class. And so there really wasn't an emphasis and support around that. It was not something that we thought about because we were thinking about how we treat the patient with the medicine. But as we said, as multiple times here, we got to think farther upstream. I was working as a hospitalist at Altabate Summit Medical Center before taking this position. And when I see people come in all the time for the same things, I think about what could we be doing more effectively upstream for them. And when I think about that specifically with food as medicine, it's providing the education for the providers who are going to be sending that prescription for broccoli or something along the sorts, and also to the support around that. So part number one is education and training, not only for providers, but for the patients. And then the second thing is how do we do that? Like, so we work with Epic, the electronic medical record. And one of the things I really appreciate from Dr. Chen and from the work that he's done with his team in open source wellness is creating a very easy and process by which we can just put in an order for the prescription and we type it in and off it goes. And one of the things that's really important, I emphasize that a lot to the county, is that having the support for being able to integrate these type of processes so it's easy for the provider and it becomes easy for the patient is going to be critically important now and also as we continue in the future as things change. So I really appreciate the opportunity to speak on this and more questions.
Thank you so much, Dr. Jenkins. Dr. Rosas, you've been studying outcomes related to Recipe for Health. Could you please share briefly the key health impacts of the program?
Sure, I'd be happy to. Good morning, everybody. My name is Lisa Goldman Rosas. I am an epidemiologist and a faculty member at Stanford School of Medicine, although I'm a Cal Bear at heart and trained. So I've been working alongside this amazing team on an ongoing evaluation of Recipe for Health, and I'm really pleased to share some of the outcomes from that ongoing evaluation. I'll touch upon the feasibility, health equity, social determinants of health, chronic disease burden, and I'll end with some findings around mental health. So first of all, we've observed that Recipe for Health is feasible to implement in community health centers across Alameda County, which speaks to what Dr. Jenkins said. We have referred over 3,000 patients since we began just before the pandemic. We've delivered over 800,000 servings of produce, and we've provided care to over 300 patients in our group medical visits and health coaching with open source wellness. Second, I want to touch upon the important impacts of health equity. So we all know that food insecurity and chronic conditions disproportionately impact our communities of color nationwide and here in Alameda County as well. Recipe for Health not only reaches these patients, but it is designed for our communities of color here in a culturally centered way. So over 80% of the patients that have been referred to Recipe for Health and engaged in the program are from our minoritized communities. And over close to 90% of them, I'll say, have some sort of chronic condition that they are managing, and this program is expressly for them. Now, social determinants of health we know to be fundamental to improving health equity. Recipe for Health has had significant impacts on food insecurity specifically, which I think is notable because remember, we are providing produce only, not all food groups. And that really speaks to the amplification effects of both the healthcare engagement and also our group medical visits. Fourth, I want to talk about chronic conditions. We have seen significant impacts on reducing the burden of chronic conditions among patients involved in Recipe for Health. So over a third of patients have experienced improvements in indicators of prediabetes and diabetes, and close to 2/3 have experienced improvements in indicators of heart disease. I'll end with impacts on mental health. I have been really impressed, having done research on mental health for a number of years, that we have seen quite significant reductions in depressive symptoms and anxiety symptoms for all patients, and especially for those patients who start the program with diagnoses of these conditions. The last mental health outcome that I'll mention is we've seen significant improvements in loneliness as well, which is a really important indicator of health, especially during the pandemic. Thank you.
Thank you, Dr. Rosas. So at this point, we're going to turn to the agricultural elements of the Recipe for Health program, and I'll start with Douglas. Douglas, could you please talk briefly about the benefits of transitioning conventional agriculture to regional, organic, and regenerative agriculture over time? You have to work on that word.
Thanks for having me this morning. I'm Douglas Gayton. I'm the co-founder of the Lexicon, which is an NGO focused on the intersection of food, agriculture, and sustainability. Among our work is the Growing Organic program for USDA, as well as Regen 1, the first place-based standard for regenerative agriculture that began in Northern California. When we talk about nutrition, we're talking about food. And most of the food we eat comes out of an industrial model that uses pesticides, fungicides, herbicides to essentially kill everything except what you're growing, which on the surface would sound like a great idea. But I think we all know the negative environmental and health and welfare outcomes that result from that model. I think from an economic standpoint, it's interesting to think that today, it's literally cheaper pound for pound to buy chicken than bread. That's our model. The farmers were the first to realize that there's something wrong with that model. And so what they did was, 30 years ago, they got together, created a movement, had no center, happened everywhere at the same time. And that was the organic movement, which ultimately was codified by the USDA as our national organic program. But that was 30-something years ago. Since that time, there's been a lot of evolution of thinking. There's been greater science. There's been a lot of expertise that has been refined in the areas of agriculture and the outcomes that we all want to see. And it's boiled down to six ecological benefits: air, water, soil, biodiversity, equity, and in some cases, carbon that can actually be a force to mitigate climate change. These six ecological benefits are part of a movement that has become the hallmark of the regenerative movement, which, just like the organic movement, is happening everywhere at the same time. But what's different this time around is that it's not just farmers, it's consumers, it's food companies, it's people in the healthcare systems that all recognize that a bottom-up movement is going to transform this agriculture model we have and return us to that model that originally was a yield for nutrition model that somehow became a yield for profit model that we can now turn back once again to a yield for nutrition model. At the center of that is this transition that farmers are experiencing that is focused on these outcomes, that is not exactly based upon the current model that we have. And we're seeing a transition from conventional to organic and regenerative. And what's amazing about this model, as study after study shows, is that it leads to very clear nutrient density results that are positive impacts for human health. They're very clear. So if you have any model that's focusing on food as medicine, you have to always get back to the fact that nutrition is food. And if you're going to choose food for a program, it should be the most nutrient dense. So I've really been excited by the work of Stephen and Recipe for Health. And we're certainly excited to see how we continue to support them. But the biggest challenge is going to be that supply chain. Because there is a will that we're seeing all over the country to support this model, but you have to get this food into supply chains, create greater awareness among buyers, and greater access to markets for these producers. And that's how you're rapidly going to accelerate this transition.
Thank you so much, Douglas. Lucia, what are some of the policies and mechanisms that are needed to shift healthcare procurement to organic and regenerative sources under Food as Medicine?
Yes, thank you. Good morning, everyone. My name is Lucia Sayer. I'm a regional director of the Healthy Food in Healthcare program, which is a program of without harm. Healthy Food in Healthcare actually got its start right up the road here in Oakland back in 2005, working with healthcare facilities to shift their food purchasing practices and improve their food service operations in support of a healthier food system. Today, our national Healthy Food and Healthcare network has grown to over 2,000 hospitals and health systems engaged in strategies around the country to do two things: to shift procurement to a values-based purchasing approach, and to invest in building stronger and equitable regional food economies that both meet institutional demand, the growing institutional demand, and also drive positive community health and wealth outcomes. So for example, the average facility in our network spends about $1.3 million on food and beverage each year, and an estimated $7.8 billion with a B dollars are spent on food for food service in the healthcare sector annually. So there's huge opportunity here. As far as the mechanisms that exist, I just want to discuss four. I just want to bring up four. First of all, healthcare systems craft and adopt internal policies that articulate their commitments to procurement and investment that help build healthier, equitable regional food economies. These policies could easily extend to their food as medicine intervention commitments as well. So they're not only committed to changing the patient food service, but they're also food as medicine is part of that larger commitment of the hospital or the system. Secondly, healthcare systems utilize a set of values-based standards, which include priority for local, organic, and regenerative criteria to ensure that they're purchasing what we all define as healthy food and track their progress and are being held accountable. Those standards frameworks exist. We have something called Anchors in Action, which is rolling out just next month, which is a framework and standards criteria for institutional purchasing and institutions that are interested in moving in this direction, not just healthcare, schools, universities, municipalities. Healthcare institutions, thirdly, increase their food contracting opportunities with local regenerative producers with a priority towards BIPOC communities and invest in the infrastructure needs of a regional food economy. So it's not just about shifting your procurement, it's about building the infrastructure in the community that's going to be able to meet that demand. We have to sort of have these parallel tracks moving. And the last thing I'll mention is that healthcare institutions need to do more of this, but invest in the relationship building and equitable regional food systems planning work on the ground with value chain and community partners that are critical for transformational food systems change. And I'll stop there. Thank you very much for the opportunity to be here.
Thank you, Lucia. Heather, can you tell us, is it possible for regenerative and organic agricultural supply chains to meet healthcare's demand for food as medicine and to do so with a focus on equity?
Absolutely, thanks, Colleen. So my name is Heather. I'm the founder of Supply Change, which links BIPOC, organic, and regenerative producers to institutional food service through supply chain design and facilitation. So how we get the food from field to plate. I work closely with Lucia and with Healthcare Without Harm through the Anchors in Resilient Communities initiative and others to achieve our vision of regional food systems change here in the Bay Area. So regenerative and organic supply chains come together through what I call the 3 Cs: connections, capabilities, and commitment. Our work is to build connections between producers, distributors, and processors so that they can deliver foods that meet the internal capabilities of hospital food programs. And if we leverage the commitments that Lucia spoke to through values-based standards, we can have incredible impact. When we turn those commitments and standards into purchase orders that flow through these food systems and through our regional distributors and processors, we create local jobs and support BIPOC producers who can build both healthy, climate-smart soils and generational wealth. So take Dig Deep Farms, who was mentioned several times, an ARC partner and a BIPOC-led farm in Fremont. This year, they'll sell over 100,000 pounds of butternut squash to UC San Francisco, and they'll also sell additional vegetables to Stanford. Or Mariana Reyes of 7 Acre Narci Organics down in San Juan Bautista, who was able to hire her adult daughters as farm business managers after participating in a program we facilitated that sold over 200,000 pounds of fresh produce into Bay Area tech companies like Google and LinkedIn last year. But our work is not done. We must continue to build bridges that endure through the Food as Medicine framework. We have all the pieces in place and are ready for more infrastructure and implementation. Hospitals can turn their commitments into contracts, and other institutions as well, by collaborating with partners on how to build wealth for BIPOC producers, health for both our climate and our people and our soils, and enable hospitals to be leaders in a circular, resilient, and regional food economy.
Thank you, Heather. So we're going to go to our last speaker who's online. Devin, we've seen the importance of philanthropy in this space. How can Rockefeller and other organizations support the scaling of regional place-based systems that connect the demand for food as medicine to the supply of organic and regenerative food?
Great, thank you so much. And thank you all for inviting me to join this esteemed group this morning. Devin Claytel, I'm a vice president at the Rockefeller Foundation. And the Rockefeller Foundation's Good Food Strategy is built around the goal of increasing access to nourishing and sustainable foods and reimagining a U.S. healthcare system that prioritizes dietary health as a core part of healthcare delivery. And Rockefeller, alongside many of our like-minded partners, is making substantial investments in food as medicine initiatives in 3 areas that we really see as key to supporting national scale and success. The first is supporting continued growth of a robust research and evidence base on the full range of benefits of these programs. And I think this may be what you were referring to earlier, Mr. Secretary, when you used the word proof. How can we make sure that we have enough proof to influence the decision makers at a range of organizations and policymakers that these are critical programs to scale? The second area is evolving those regulatory and policy frameworks to support the growth of BIM, and we've seen a lot of exciting innovation and movement in that space in the last year. And the third area is supporting infrastructure, including a thriving ecosystem of local and regional partners that we think is needed to incorporate food-based interventions directly into our health system. Our end goal, as many have alluded to today, is that these programs be scaled and integrated into coverage as a medical benefit, just like any other covered care, so that they can reach all Americans. And this is part of where we see the important link between food as medicine programs and how we can create a more sustainable and regenerative food system. Like I've heard from many others this morning, our strategy seeks to improve how food is sourced, to advance environmental sustainability and ensure equitably distributed benefits. And as the previous speakers were outlining, schools and hospitals and other institutions across the United States spend as much as $120 billion per year on food annually, which means they have tremendous influence over our diets and our food system through their purchasing decisions. And so we at Rockefeller work with groups like the Growing Justice Fund and the Equitable Food Oriented Development Collaborative to develop a pipeline of BIPOC food and farm businesses that build wealth in underserved communities. We support organizations like the Center for Good Food Purchasing and Healthcare Without Harm that provide rigorous standards and technical assistance for good food procurement. And I think it's important to note, as others have, that historically so many purchasing decisions were based purely on sort of the lowest bid and point us to the cheapest food. But through our own true cost of accounting research, we've seen that when you consider the full impacts of the food system, including environmental equity and human health impacts, the cost of the food we're eating today is really 3 times what is showing up on the price tag. And so we're working with those that can influence purchasing decisions to evaluate the full picture of their procurement choices on health of those they serve and the communities in which they live. And I'll just say that Recipe for Health is an excellent example for us of how good food procurement and food as medicine can be leveraged together to maximize benefits for health and community. And we feel, as I think many in this room do, that if food as medicine policies and programs are adopted nationwide, there's tremendous opportunity for that institutional purchasing power to further support healthy individuals, healthy food systems, and a healthy planet. Thank you all.
Thank you, Devin. We've heard from a variety of leaders in this work, from a range of roles that they play to advancing food as medicine. In addition to the folks that you've heard speak, I just want to acknowledge a few other of our important leaders who are in the room here with us today. Dr. Jeff Reynoso, who's the Region 9 Director for Health and Human Services. Dr. Glenda Newell-Harris, Regional Medical Director for Yes Care. And Jesus Mendoza, the USDA Regional Administrator. Thank you all for joining us also. So I'd like to turn it over to Dr. Chen for some summarizing comments and to close out the roundtable portion of this conversation.
Thanks so much. By bridging the demand for food as medicine with the supply of organically and regeneratively grown food in an equitable manner, we are creating force multipliers for health at the individual level, at the economic system level, and the planet itself. These are all force multipliers that ultimately improve our health across the spectrum. We solve for an underlying mechanism that's often been overlooked for these chronic conditions by addressing the poor quality diets, and we center this work with equity and a focus on quality for all communities, the quality of the type of food. We have a number of recommendations, and I'll throw it out as a way to then lead it into the next part. As we think about this roundtable and what we've talked about, our first recommendation is to adapt and scale Alameda County's Recipe for Health Food as Medicine recipe across the nation through the Congresswoman's National Food as Medicine Demonstration Project, through the 1115 waivers in 8 other states, Medicare, Medicare Advantage, Original Medicare, the VA, and Indian Health, to ask this question where the food comes from and to design accordingly. Number 2, the president called for an all society approach. And so we know that not one sector can do it all. So we're calling for an interagency authority between HHS and USDA to guide other food as medicine efforts to explicitly tie this demand of the high quality nutritious food as medicine by healthcare to the supply, and to ensure that the equity guardrails are in place. Number 3, to support sustainable and equitable impacts by making food as medicine services a fully covered benefit in Medicaid and Medicare. Not only these 5-year demonstration waivers, but to really, as Devin was saying earlier too, to make this a covered benefit, a required benefit. And then the 4th, to use for HHS to help use these policies that Lucia was talking about to encourage healthcare institutions to prioritize and procure organic and regenerative foods grown regionally, locally, and equitably with attention to farm worker health and BIPOC supply chains. I want to thank you all for your time and attention today. I think the late Supervisor Wilma Chan is smiling as she sees this conversation and as she sees your leadership at the federal level taking this and scaling this work nationally. Thank you all very much. I'm going to turn it back to Director Chola for next steps.
Thank you so much, Dr. Chen. And I think we have maybe a little bit of time for some Q&A, and I would love to turn it over to you, Congresswoman Lee or Secretary Becerra, for any questions you might have for anybody in the group.
Sure. Well, I will just first say thank you all. This has been a very important discussion, but it's also been enlightening, and it's also very clear that we have to work in an intersectional manner. And that the interagency agreement recommendation is certainly a great idea, I think, Dr. Chen. And I wanted to ask Devon, I know you were at the Hunger Conference, the White House Conference on Hunger, and I believe that the Foundation, Kroger, and American Health Association, you all planned or announced a plan to mobilize about $250 million to build sort of a national food as medicine research initiative. But I'm wondering, of course, you've heard what is taking place here in Alameda County. We've hit the ground running, and we could mobilize almost immediately. So how does the research initiative, are there provisions in this initiative that would allow for communities which are actually implementing the food as medicine programs to be included as part of the research initiative that was announced at the White House Conference on Hunger?
Yes, absolutely. And one of the things that we're in the process of doing as we stand that initiative up is pulling together groups of experts and practitioners and others from across the field, both rigorous academic researchers, health systems, but also community-based practitioners and organizations to inform the research aspect of that initiative as well as the other pieces of the initiative. So we'd welcome input from anyone in this room and to bring some of you all into the conversations that we're having right now in terms of how to design that initiative and develop the research. And I would also just say, Mr. Secretary, we'd love to work with some of the research experts you have in your organization to make sure that as we develop this research, that it is the most meaningful and as rigorous as your agency would need in order to shift policy and regulation to support scale up these programs as well.
Great. We know that public-private partnerships seem to be kind of a strategy that I know under the Biden administration sees as a very important kind of strategy to address the many challenges around equity, around healthcare, around all of the issues that underserved communities quite frankly face. So I think that's a really good idea, and I'd like to yield now to the Secretary and get his feedback and comments before we close.
So first thing I'll say is I have some of my team here, and Dr. Reynoso, so we'll try to follow up, Devon, on that point about how we make sure the research coincides and that we can make the most use of it as efficiently as possible. I wanted to make a quick comment on the matter of physician training, which it's kind of shocking that nutrition is sort of a afterthought. And if we could talk about that, because as we go out and distribute these graduate medical assistant slots to medical schools to train the next generation of health professionals, it'd be great if we could try to move in a direction that sees medical schools doing far more, hospitals doing far more in training up our future physicians to actually think of food as medicine as one of the things they look to, not just some difficult to pronounce prescription as something that will treat human beings. But the one question I did have is I was wondering if you could comment to me, how far along are you on this subject of incorporating the schools in this program, since they have such a large food program? We've got our representatives from USDA, Mr. Mendoza and his team here, my team from HHS. Right now, Secretary Vilsack, I know, is very interested in trying to see how we adjust the nutrition program, SNAP and all the rest, to better accommodate this idea that food really is medicine. And I've been talking to Secretary Cardone at the Department of Education of how we get more schools into the Medicaid program directly, so they can actually become providers of healthcare services and qualify for Medicaid reimbursement. It's a tough road because they have to be able to meet certain standards, but we want to work with them to see if we can get some schools to buy into the idea so they can get this population of kids, many of whom are Medicaid eligible, into the system quickly. And certainly when it comes to this idea of food as medicine, you've got a captive audience every day for 5 days a week. How can we get USDA, Department of Education, Health and Human Services to work together to make sure that anyone who wants to take us up on that challenge, especially at our schools, can start driving this big? And if you want to scale, let's do it in our schools, our public schools. So I offer that as a question.
I think that's a great point. I think it's one of those things that working with those collective agencies together would be great. I do feel that for training, specifically for medical students in particular, it's one of those things that it's easy to, I feel like it would be more easier to do only because like they're there doing education and other things, curriculum already. And then it's just pushing it there. Now that wouldn't be, obviously private schools might be harder to do or certain things, but I think
they ask us for a lot of money. So
yeah, and they're going to ask for, so just keeping that in mind. But I do feel that the opportunity is there for at least to begin with the discussion and seeing what would you kind of layer on. And I just thinking back to my training and, Dr. Chen's training and other people, it would be easier to do it kind of as you're getting ready to be in like your third year, fourth year, or even, making a requirement saying this is going to be part of the education. part of your education is going to be not just how you deal with congestive heart failure or hypertension or diabetes, but it's going to deal how you deal with nutrition. So I feel like that would be another start where it's not so much, I mean, you wouldn't have to negotiate that as much with the individual students of the curriculum, but if you say, hey, we want you to have this as part of your training, then that will continue on so that the things that I'm doing in the hospital can be easily replicated, you know, in a similar way in primary care for hunger and nutrition.
Well, we're interested in whether it's the GME, the graduate medical education slots, or however else we can try to drive it. I'd be very interested in that.
Yep.
That's such a good idea. I think Dr. Chen was also going to respond about schools, and I know we've got to wrap up because we've got another event right after this one, so maybe after Dr. Chen.
And I know Hillary wanted to add in as well.
Oh, gotcha.
Dr. Chen?
Okay.
Absolutely about training. We already have a 3 to 4 hour training that we trained right now. The clinicians who are practicing, they've been out of training and now they're getting retrained to actually do this food as medicine mindset. But you're absolutely right. It has to happen upstream in the development of nurse practitioners and clinicians. And I think GME is the way to go, the graduate medical education, making that a requirement. In terms of the schools and healthcare, there's a wonderful intersection there. Our work here in Recipe for Health is focused on healthcare because I think at some level, food systems have been doing innovation for a long time. We've needed healthcare to kind of take the mantle and say, we're going to use and leverage our strength in healthcare to help take this on. But in the same way, healthcare touches into education, and your idea of connecting schools into Medi-Cal spaces, there's wonderful work that could just be bridged from a procurement perspective that Lucia was talking about, from a training perspective in terms of how we train everyone and creating the education, and then also just the food that's provided for the students. So it can be, again, a whole society approach. Right now, we've been really focused on healthcare because I think we've been fairly asleep in terms of healthcare, in terms of using food as a medicine, but that's changing.
Thank you, Dr. Chen. Hillary.
Yeah, if I could just add a little bit on the school side. And I, like I said earlier, I've come at this really from an economic development perspective and trying to figure out this business model of local production and paying, $20 to $40 an hour for farmers, which is really unusual, I think, in America. And I've been sort of going at it just head first and bumping into where the barriers are. And one of those was sort of accidentally because I went to our local school district in San Lorenzo and I said, hey, we would love to see if you could procure some of Dig Deep Farm's produce as part of your school meals. But the problem is really around the school budgets, the meal budgets. And I am under the impression that, I hope this is awkward, but I think my understanding is that I'm learning that the USDA there's a relationship with what the reimbursement rates are for schools as well as the SNAP. But what I've taken away is that there's an opportunity perhaps to increase those reimbursement rates for those institutions, because if those procurement budgets can't change, as Lucia's been working on, then the procurement itself can't change.
Thank you, Hillary. So I really want to thank everybody for participating today, and a special thank you to our esteemed federal leaders for being here and listening to this important conversation. We're looking forward to next steps. We heard your challenge, Mr. Secretary, and we're ready here in Alameda County to take it on. So thank you very, very much, and thanks to everyone for being here.
Thank you all.
Thank you. Thank you.